when we talk about the future of CLL and we talk about these combinations, and there are many studies running looking at multiple combinations, as I alluded to earlier, looking at a BTK plus a BCL2 inhibitor, even triplets, that's doublet combination, even triplet combinations looking at a BTK and a BCL and venetoclax and a monoclonal antibody. There are chemo novel agent combinations with reduced intensity chemotherapy plus a novel agent like a BTK or venetoclax. And so there are multiple strategies looking at how, whether or not doing these other options might be better for disease. As I alluded to earlier, I think it would be naive for any of us to think that these combinations wouldn't have great efficacy in our patients, and they do. Albeit, and so those combinations are often then time limited, which I think, you know, is an advantage and appeal for many of us and our patients, that they're not on chronic continuous daily therapy. However, I think we have to figure out whether or not that's appropriate for all. Is one, you know, unless we see these dramatic, we will see, as I said, high response rates. One thing we need to learn about is how long that will last. How do we salvage those patients who have gotten a doublet or a triplet? You know, what they will be sensitive. Have we changed the resistance pattern or the milieu of their CLL or complications that they may incur by those doublets or triplets? And so I think there's a lot to learn. And so I don't think we have the right answer just yet. And so that's why that discussion of do you do in frontline monotherapy versus a Ven-OB combination with your patient, I think is relevant because it's a preference and there are many factors to consider. So unless there's something that, you know, that really stands out, I don't think we have the answer that one is better than another just yet. And again, there are many trials looking to address this issue. And so that if they start this combination and whether they continue one of the agents versus stopping. And so there'll be many randomized studies that hopefully, it will take us time, obviously, to figure this out, given how well patients are doing. You know, this data just got presented recently at ASCO, the updated data of long-term ibrutinib or acalabrutinib as monotherapy in frontline, really great PFS curves in the frontline untreated population, albeit those patients are continuing on oral therapy. But you could see that patients are doing really well with these novel agents. And so figuring out, is there one strategy better than another, is going to take us some time to do. Obviously, there's a great appeal to get people off of therapy, and not for many reasons: financial considerations, long-term toxicity issues because they're on chronic continuous therapy. There's many advantages to looking at time-limited durations of therapy, but of course we have to look at also the side effect issues, change of resistant patterns. How do we salvage those patients after, things like that, right? Because then our patient population only gets older. You're going to go back to chemoimmunotherapy, you know, so there's a lot of factors to consider. And so having those patients appropriately enrolled on these clinical trials, I think, is paramount. I think it's very important as we study these exciting combinations to figure out long-term what might be the best strategy. And again, it may not be, unless there's a home run entirely, it may not be that one size fits all. And so I think there are many patients who are completely appropriate and happy and content to be on monotherapy. And so I think just stay tuned. We'll have to see, but many exciting combinations being evaluated currently.